Good morning, ladies and gentlemen. Namaste once again on the fourth day of the biggest implantology event of 2020. We hope you all set for a yet another power-packed day comprising of lectures, masterclass sessions, and a lot more. Good morning, ladies and gentlemen. A very good evening to everyone who's joining us from various parts of the globe, and also various forms of namastes to everyone who's joining us from various countries, from the Middle East, from Europe, from Northern Africa, from the US, and from various other countries. We warmly welcome you to this session. Ladies and gentlemen, my name is Ruben. I am your host. I am very excited, delighted to be a part of the world's first virtual Implant-Expo as your moderator. Ladies and gentlemen, last evening I asked you one simple help, and that was to get a friend, to get your fellow implantologist to this virtual arena. I hope you keep up to your promises and you're getting at least one buddy of yours so that no one misses on the biggest implantology event of 2020. Ladies and gentlemen, let's start with today. Today we have with us the first session. Ladies and gentlemen, always the first session seems to be the most power-packed sessions because of the kind of speakers that we've had right from day one. Dr. Johnson James, to yesterday we had Dr. Shiva Shankar, the first person to begin his CAD CAM journey in India, to today a person who's doing a wonderful job, a remarkable job in 3D printing and customizations with regards to everything that comes in the world of implant dentistry. Yes, ladies and gentlemen, I'm talking about our next speaker for today, Dr. John Nesan. A short introduction about our speaker. Dr. John Nesan completed his MDS in oral and maxillofacial surgery from Sri Ramachandra Dental College, Chennai in the year 2008. His PG thesis was the role of stereolithographic models in oral and maxillofacial surgery. He pursued his thesis and went on to make it as his career in the field of 3D technology in the healthcare domain. He is the director of CTARS, that is the Center for Technology Assisted Reconstructive Surgery, which specializes in 3D printing, designing, and on-printing of dental implant guides, orthognathic splints, and custom-made patient-specific implants for the cranium and the maxillofacial region. CTARS is the first unit in India to commercially start virtual surgical planning for orthognathic surgery. CTARS also is the first unit in India to design and fabricate zygomatic implant guide done in collaboration with Dr. Johnson Raja James from Chennai, India. With over 223 plus doctors, 13 academic institutions, and 25 hospitals as their clientele, CTARS is the fast moving on to become one of the top companies in India in the healthcare 3D technology space. Dr. John's passion is to bring the best in technology to the needing patients in India. He is actively promoting the applications of 3D printing to the healthcare community. He regularly conducts CME and CD programs on 3D printing in medical, dental, and engineering institutions all across India. Having delivered over 100 lectures on technology-based healthcare applications offline and now almost 20 lectures and demonstrations online. Ladies and gentlemen, here's one more session by our very own speaker, Dr. John Nesan. Presenting to you, Dr. John Nesan live.
Hi, thank you, Ruben, for the wonderful yet lengthy presentation of me, and I hope I stand to my credits. It's such a great joy for me to stand here and to be a part of the world's first virtual dental implant expo. Thank the organizers. I know it's a very tough job, but I think you guys are doing a great job with this. Let's get straight on to the topic of today. So I hope this is clear there.
Yes, sir.
All right, great. So today's topic is not a it's a very common topic today in most webinars and most technology-based work. You will be talking about the role of 3D printing. So today, my job is to explain to you what 3D printing is and what is its role in designing and manufacturing of patient-specific implants in dental implantology. I think we've had a power pack session the last 3 days of dental implants covering every aspect of it, and a few more days is there. And today I'm going to take a more practical approach. Today the whole world is talking about customization. We're talking about customized clothes, customized buildings, customized rooms for us, customized wear, personalized things. So if we can do a lot of things on customization, why not make our healthcare, why not make our treatment also customized? I mean, that's also where we are going forward, right? So implantology, as we all know, is okay, the process of replacing your teeth. And if we can customize it, I mean, have you ever thought about it? Making a specific implant for a specific patient and using it for that? Is it possible? Let me take you to this journey of what is possible and what we can do with 3D printing in customized implant for dental implantology. So I'm John. I'm a maxillofacial surgeon by profession and also a director for STARS and the joint secretary for 3D Para, and I also work in Apollo Hospital. Today we have science being talked about everywhere. Today there's, I mean, especially in this pandemic time of COVID, you know, everybody's talking about health, health, health. I mean, no longer wealth was not that important. Today health is wealth. And science has today progressed so much. I mean, these are the times, if you look at this image, where anything that we wanted to look at, we also had all 100, 200 people had to come in. We had to have, you have to have an examiner. You have to see. Seeing is believing, right? That's the way we all started. That's the way over 100 years ago, that's the way operations were held. But today, that is being challenged. With technology, the skill is not challenged. Science is not challenged. But the way in which we are doing our procedures is challenged. It is changing. Today, with science and technology taking a big grand stand today we can do so many things which we thought was not possible medically. Today we can explore better, we can see better, we can see the human body much better, we can understand its science much better. So when we are doing so much, when we can think so much, no, can we use technology for our benefit, for our things, for our customization? That's where 3D printing comes. So that's where my topic of today is going to be. So I believe in this topic. This saying is probably 100 years old. This was said by the Wright brothers. If we all worked on the assumption that what is accepted as true is really true, then there will be little hope for advances. You want to keep changing. You want to questioning, okay, is this the only way I can do it? I mean, I still remember when we were taught implants, we all thought of parallelism is the thing of the day. You understand? But today, parallelism is also being challenged today. Today, you have tilted procedures being done, which is giving you a much better results, if I may, in some cases, right? So there is always a challenge, and you challenge of what is the norm. Today, what is the norm today may be different in the next few years to come. So always as you start questioning this, then there is always room for big advances. So I'm going to talk about additive manufacturing or 3D printing. So what is everybody's talking about 3D printing today? No, like, I mean, you can make toys the way you want to, you can make dolls, you can make all these engineering parts, but is that all? Can we do more with that with 3D printing? And what's that got to do with healthcare? What's that got to do with implantology? This is a technology which is not going to die out in the next few years. This is one of the top 30 technologies for the next decade. We're talking of 3D printing in combination with artificial intelligence, in combination with blockchain, with big data. So that's how 3D printing is going forward. It's one of the few technologies where all the other technologies, if you look at it, it's all more virtual. No, it's all more digital. If you want the digital format to come into physical for you to touch and feel, then 3D printing is the only format available for you. So it is a process of making three-dimensional solid objects from a digital file. We have CT scans, you have X-rays, then you had CT scans. So all that was digital, right? It's a two-dimensional work. But what if you could actually touch and feel what you were seeing in a 3D, in a scan? What if you could actually hold it in your hands? You could actually see the part, measure the width, see the length, feel it, feel factor, the fourth dimension, the feel factor we are missing out, right? What if we could do that for our patients? Imagine the kind of treatment that you are going to be able to provide. That is how 3D printing is going to be make things better for you. A lot of articles have come up day in and day out about cervicals. This is one in the Middle East where they perform the cervical spine. A lot being done in mainstream, in healthcare, replacement part. So the first thing that we think is, man, if you talk about 3D printing, you're talking more about all the other parts of the body, legs, brain. You're talking about implants, cranial implants, mandibular implants, orbital implants. I mean, instantly, all these are all done by stars. So, yes, they have a big role. Yes, their majority is them. But then that's not all. There is more to it with 3D printing. Today, if you talk of digital, if you talk of customization, technology assisted, this is the technology that you need to go into. So the way we treat our patients is changing. I mean, I've been practicing for the last 20 years now, and the last 10 years more into dental implantology. I mean, I was trained under the great professor, Dr. Gunaseelan Rajan. I started my career from him, and I mean, yes, every form of implants is being done there. And when Johnson Raja sir, we started tying up with Dr. Johnson Raja. I mean, the exploration that we had with him. So my journey has been with great people. Yes, but conventional implants is here to stay. No doubt about it. We're not challenging that. But the way we treat them, the way we use conventional implants is changing. And we better be prepared for the change or we are going to miss the bus out over there. So today, like I said, why are we going to miss out today with digital technology? If you're doing dental implants, all of you over here, I mean, you understand the power of CT scans. No longer, yes, your X-rays are a must. X-rays are there possible when you can't have your CT scan. But that's a two-dimensional way. You can only see the length, but we can't see width, we can't see anatomy, we can't see how close it is to the other structures, anatomical structures. So the role of CBCTs on your CT scans is playing a big thing today. Intraoral scans are a game changer today. It's still in the slightly in the not affordable range, but yes, that's also coming in with scanners like Medit and all those things are bringing it very affordable. And then finally, 3D printers. I mean, we are very proud to be associated with Formlabs as one of their partners for India. So again, 3D printing machines are changing. So when we have good machines, affordable machines, the end output is really better. So this is the way your guide can come in if you use the recommended resin for you to make a guide. And all this is done on planning softwares, right? So it's no longer just you seeing something and then you're taking for chance to say, okay, is this the way I do it? Today, with better planning softwares, with better technological advances, we can measure the length that we have and the width that we need for us to choose an implant. No longer do we need to buy big ornamentarium. If we wanted to place an implant, I still remember I used to I would order about 5 implants, for just for one anterior implant or a posterior, because it could be a little length, it could be one side drilled, it could be there could always be discrepancies. But when you plan it with 3D, you know precisely where you're going to go. That's the biggest advantage. So why is 3D technology moving forward? Number one is with CBCTs today, you have awfully good CBCTs that have come up. I mean, I think the scans, when we used to do conventional scan, it used to be 1 mm size thickness. With CBCT, it is about 0.6, you can do it. So that's the big game changer today. And also the cost also. I still remember the first CBCT when we used to take, used to be 5,000 rupees. Today, I think you are able to get a CBCT scan at 1,000 rupees or 1,500 plus. Number two is virtual planning. Softwares used to be again a thing which only the West used to have. I still remember sitting in Rajan Dental, we used to plan it, a noble clinician, and then sir used to send it to Sweden to get the guide. It used to take us about almost a month, and it used to cost us, I mean, I don't know, it used to cost us close to about almost 30,000 rupees. But that's changing today. Today we can do it in-house in India. If you have a little bit of a budget that you can spare, you can have it in your own clinic and you can get it done. So virtual planning is a big game changer today. And custom-made implants. Today, again, thanks to 3D printing additive manufacturing, we can make our own implants if we want to for our patients. But is that practical? Where are we? Yeah. So what are the 3D printing technologies used? So this is basically a small introduction of what technologies are being used and where do you use them. Number one is on fused deposition molding, or we very commonly call as FDM. These are the machines which you have starting from 25,000 goes all the way up to a lakh. Okay. Most of them, most institutions have these kinds of machines. So you can print a model with this. It's very good for printing a model, not the best for printing a guide. Okay, because it is still coarse, it's still not very finite. So I would not choose them to print a guide, but printing a model for you to practice, for you to see to the patient, for you to show the patient, tell them this is probably how your bone anatomy is, and this is the reason why we are choosing an all-on-4, or why we are doing a zygoma, why we are doing a pterygoid. It's a great choice to use the FDM machines. The SLAs, or today we have stereography, we have DLPs, this direct light processing units. So these machines are a game changer today. And so today with farm labs coming in and with good biocompatible materials which are approved to use for dental implants, that's being a big game changer. So this is the way your implants will look, the guides will look. I mean, the metal sleeve is what we customize and do it. And finally, the DMLS methodology for you to print your own implant. So the science of today is the technology of tomorrow. Where do you use 3D printing in implant dentistry? Big scope again in dental health and in surgical work, but in implant dentistry, where do you use them? I've categorized them again into three basic types. One is where I use them as a prototype. Number two, how do I use them as a 3D guide or a splint? And number three, for custom made patient specific implants. As a 3D model, how do I use them? So this is how we print our maxillas and our mandibles. This is done with, again, with Formlab with a clear resin. This is done with another resin, but it is more a little bigger machine that we printed. So what do you see? Why do you want to take a model? Two things. One, for me to show to my patient, and also for me to understand what the anatomy is in case there is a little compromise on the anatomy or it is a little bit more atrophic. You want to have a better understanding of the whole structure. Number two, for me to practice my implants. See, when I take a model like this is because it's taken from the CT scan, it is a 1:1 ratio. It's the actual size of the patient's jaw. You understand? So you can practice over here. You can place your implant over here. Like for example, if this is the way I want to look at the implant, all I can do is just put in an implant like this, here, or a zygoma if I want to do this. I hope you guys can see this. And then, yeah, sorry. That's the way I place my zygomas. And then if I want to place my anteriors, place them here. You know exactly where you are. That's how advantageous the models can be. Again, number two would be for me to position it on a guide. Okay, I have made a dental implant guide, but I want to position it. So you print a model prototype, put the guide on top, and then you see whether it fits well. And then actually once you place the implant guide over there, then you can drill the implant directly. So you exactly know where you're going in, no surprises. So this is one way of us trying to look at how we can use prototypes. We do this a lot for training. So people want to look at training. I mean, again, with the help of support of Dr. Johnson Raja. I mean, in case he wants to use it for training, he says, John, I need a couple of days for people to use it for the zygoma trainings and all. So we print models and we give it to them. So they can practice on this instead of you actually having an actual skull, which is there's no compromises to it. But the same anatomy is here. That's the biggest advantage. No? The same anatomy, the same dimensions is replicated over here. So number two is in 3D guides and splits. So wherever you use them, number one, like I said, in dental implant guides, you use them. This is a lot of centers in India today use 3D implant guides. So it's available across India. You can take the use of any center that does it. Just see what material they use and how they plan it. Number two is here is a case. I mean, this is again, I think we showed it, where we made a guide, a custom made guide, where we had a combination of a conventional implant, a zygomatic implant, as well as a pterygoid implant. Imagine getting all the three at one go itself. So that's where you use the guides. So to performing this is no jokes, you understand? Because imagine the kind of planning that you would need, positioning, and the expert skill hands that you need to have. But again, with a little bit of help of technology, you can do it very comfortably. It saves you on time. You don't need to put multiple punches on the bone. And yes, your results is as predicted as you want. Cutting guides. This we use it quite often when some people come and say, John, I have an immediate extraction and I want to load it. Because when you do a case, when you work on immediate extraction procedures, you realize the ridges are not equal, right? Most of the time they come with you with CD, chronic obstructive peritonitis, right? and a grade 3 mobility, and you have different levels of the way the alveolar crest is. The best is you make a guide. Once you cut the guide, the bone, see, this is the way, this is the example that you show. So you see the bone over here, and when you use a guide, all that you have to do is place the guide and then chip it off. One small smooth slice with your bone burr, and then it is done. And then you can comfortably place an implant, or again, you have an option of placing a guide on top and then fixing it. This is how the trimming guides would sit. They will use it. It's a little bit extra time with respect to time and cost, but then your results are perfect. I mean, this is not my version. This is what anybody who use guides will tell that to you, right? So again, that's for a maxillary bone guide that you will get. Okay, now we'll come to the main topic of today. Where do I use it in patient-specific implants? Now, I have, this is again my indications. I mean, so it's not from taken from the book, from because of we use it now for the last almost 4 years. The longest follow-up I have is from my first patient, which we did again with the help with Dr. Veerababu. So sir was very kind enough to come and do the first implant, custom-made implant that we did for a maxilla. So we have a 4.5-year follow-up of this patient. Touch wood, God's grace, so far so good. So I use them a lot when we have atrophic maxillas and mandibles. Sometimes you have a compromised dental alveolar segment. It's been traumatized because of trauma or any other things. You're not sure. I mean, there has been a small cyst over there. There's a pathology over there, or the anatomy is slightly changed, and you're not sure whether the conventional implant will work, or there has been repeated times. I mean, an implant has already been placed over there and it's been explanted. You're not sure of things. Don't take a chance. The best thing to do a customized implant. Anatomical landmarks, when you have sinuses coming inside, when you have the nerve running here and there, okay, and you know, I think you don't have enough of good bone that you want to think of. This is the best indication. If you want to do additional bone augmentation procedures, many times we are so comfortable when we have a bone loss or a reduction, less bone, you think we straight away think of augmenting it with bone grafting, either an autogenous bone graft or an alloplastic bone graft. You start taking it, put in a graft, wait for 3 months to 6 months, and then put an implant, and then you wait for 3 months, and then you start loading it. Those can be avoided with customized implants, right? I mean, I'm not saying those are not good. They are great. There's nothing like having your natural bone as such, but not always does it work, right? Time factor. When you want to immediately load, this is something which most of our patients are going to come. Or I feel most of the patients who come to me, I don't know about you all, but when they come to me, they say, John, I want teeth. Nobody comes to you and say, I want an implant, right? I want to fix a teeth is what they want to come in. We as dentists, we as implantologists, we as surgeons, our role is to, what is the best medium for us to provide the best answer for them to give them fixed teeth, right? That's where they come to us, no? So you can choose whether you want to do a bridge if there are teeth, or you want to choose an implant, you want to use a conventional implant, all on 4, all on 6, you want to do a zygoma, you want to do a pterygoid, or you want to do a custom-made implant. That choice is yours. But ultimately, the patient wants is teeth, okay? The finally is when you have a failed conventional implant. Okay, this I already mentioned this. So when you think the conventional implant has failed, you can't go back again. You want to graft it, you want to leave it for some time and then do conventional, then do again, then you want to re-enter the site again. Don't even think about it. Straight away get on to customized implant. What are the contraindications and disadvantages? Insufficient soft tissue cover is the biggest problem that I have faced whenever we did it. I mean, we have today, again, by God's grace, we have done close to about 50 customized implants for maxillar mandibular frameworks, okay, for in dental implantology. I think it's about 49 or 51, I'm not very sure, but round about that figure. The biggest disadvantage or the biggest problem, or which I always tell my doctors and we want to work with, boss, please see that there is good soft tissue cover. If there is no soft tissue cover, do not even try to work on these implants. Okay, that's the most important thing, because any implant that is exposed will always give you a problem. A little bit of an exposure here and there for distance is acceptable, because that they will anyway cover up with soft tissue by secondary growth. But if the entire implant is going to be open, we have a problem. So please see that there is good soft tissue that you can cover. If there is no primary good soft tissue, think of what you're going to do to cover it up. No, like, okay, can I do an advancement flap? So think of those kinds of procedures that you want to do to cover up the implant. If you can cover it up, great. If you can't cover it, this is not the first choice. Number two is if the patient is allergic to titanium. Yes, all the customized implants we do are made of titanium. They are a titanium alloy. It's PI6Al4B, grade 5 titanium, medical grade, which is used and approved. So if the patient is allergic, then there's nothing that you can do about it. You will know it in a couple of weeks itself. No, patient will start developing. Actually, after you place it, that goes the same even for dental implants. Implants are also made of titanium, right? So when you place an implant or a customized implant or a conventional implant, patient, I think the second day or third day, will start developing small irritations, rashes. I mean, when the patient comes to you with any of these complaints, you know there's a problem with him, take out the implant. Okay. The third choice, which I felt was my prosthodontic options are slightly limited. What do I mean by that? When I'm talking about custom-made implants, most of the time they are cemented processes. So when you have a cemented processes, I straight away can't load them on with a procedure like a zircon procedure if I want to do it, or an all ceram, not immediately. I have to go through a process. I mean, I would rather first immediately load them on something very lighter like an Odoro processes or an acrylic, and then go on into ceramic or zircon processes. Number one. Number two is today that limitations we are changing. Like I said, currently this is a small limitation for me with the prosthodontic options, but that is slowly changing with screw retained processes. So we are now slowly moving from cemented to screw retained. When we have screw retained processes and the role of multi-unit abutments taking over, any processes is fine with us. So we've worked on it already, and I think we've done one case with the screw retained processes. Now all the other processes that come in will come with both the options, cemented or screw retained. So that's being covered. All right. So this is the way you will get a patient. So what do you do when you get a patient like this? Okay. This is the way the patient's anatomy looks three-dimensionally. Can you see this? I'll just shift over to a little bit. Yeah. So this is the way the patient's bone is, how thin over here. What do you want to do in this kind of a patient? Okay. You have an option. I can do a conventional implant here. Do an okay, I don't know why this is going like this. I'll go back to highlighting it. Okay, I can do a conventional implant here, or I can do a zygomatic implant, right? Like that. But what if my bone is less? What if I had bones like this? I think the maximum width of the bone here is going to be about 2 mm. Yes, so how do you do it? I mean, you need to really augment it over here, right? Number two, posteriorly, have a look at it. Have a look at this site. How do you augment over here? You have to do a sinus lift. We have to leave it, put a graft it, leave it for a few months, and then think of an implant procedure. Can we avoid those? Okay. So these are a few cases which we have done, and I'll show you how we use it for an atrophic maxilla and a mandible. This is a small video presentation I think we have of where we used it. So this patient came to a senior doctor again in Hyderabad, and he came and said, John, this guy needs implants because he normally does zygoma implants. So he said, John, even zygomas are a little difficult. The only condition is the patient wants permanent teeth fast. So I said, okay, let's go in for the planning. So on the plan, we realized he had only 2 mm bone and 1 mm bone posteriorly. With that kind, you really can't think of conventional implants. So we did a customized implant. This was, I think, our 5th or the 6th implant that we designed. It took us normally it takes you about a week for you to design and print this implant, place them, took a support a little bit both in the mandible and the maxilla, solidly sat on the bone. The biggest advantage here is we had the processes also ready. So when you do a 3D printed implant, you can have your temporary processes ready on the same day that you even place the patient, you can fix it on it. This is the post-op X-ray. This was done by Dr. Cheevan and his son, and so this is where we started in, this was I think a first case in Hyderabad that we started this. So a very similar profile of that. And just to show you, that was the video, and I'll show you what we did for a patient. Very similar, again, a patient which we did last year. Thanks to Dr. Srinivas Reddy. Okay, a patient came in like this. He said, John, patient profile is almost like a very elongated face. He's a denture wearer. The biggest problem that when you have people who have denture wearers are, you need to be very clear the bone, that the ridges will always be knife edge ridges. Okay, and they will be because of bone resorption, and especially if they have a loose, ill-fitting denture, you're finished. The bone that you have is going to be extremely limited. So those kinds of patients, please be very careful before you touch them. Take a scan. Do not attempt them on an X-ray. Okay. So one is the patient profile was my problem. Number two is the maxillary sinuses. I'll show you in a minute of how the maxillary sinuses sat. Number three, my inferior ridge is also there. Number four, and the final and the biggest problem for me actually was, and is always going to be, my patient's expectations and demands. Doctor, I want teeth. I want nice teeth. I want teeth that looks like that. I want my face to be like that. That is what they would come in. Many a times, yes, if there is a little bit of an issue with cost, you can always get away. You can say, no, it's going to cost you so much. So therefore, we are doing these procedures, and then you can always compromise. But then if the patient comes and says, no, cost is not the issue at all, give me the best, then you really have to look at what options you have. Okay. So this was the case. So let's see what we did for this patient. So when this patient, this is the patient's lateral profile. You can actually see how thin the bones are, and both in the maxilla and the mandible. And zygoma was an option for us, but then the patient didn't want to go in for zygoma for the only reason is we were not sure how the anteriorly the bone would support. I know for sure there's good amount of bone on the zygomatic region, okay, at the region of the carina where I'm going to secure a solid bone I have over here. But anteriorly, I'm not very sure how much it can support. Because then when I start loading it, that's the biggest problem with zygomatic implants. All those who do zygoma implants will be very sure of this. It's a trajectory, right? So when it comes at an angle from here to here, okay, the entire load that is going to be pushed is like this. So if you don't have a good support, then this can break. And if it opens up, or if it cracks or it moves, then you don't have any other option of placing it. That's the biggest problem with zygoma. If your zygomatic implant, again, the process starts loosening or there's a slight shake, then this whole region starts to get widened, you will lose what you have. Okay. So we said, okay, that's not the possible. So this is where the sinuses. Can you see how the sinuses are? Okay. I have absolutely no bone for me over here. So my only limitation was on my anteriors. So we thought, okay, can we think of an anterior all on fours? Not possible because the bone width is only about 2 to 3 mm width over here. So we said, let's do a custom-made implant. So this is the way we design. See, when you do a designing, I just showed this image to show you how we design. So we can safely avoid the sinus, go where we are, and then we use these support from the zygoma. If you look at this image, it is actually the same as how a zygomatic implant would come. Having assisted almost close to 30 cases with Dr. Gurusevan Rajan, okay, and myself done, I think I've done a couple of zygomas myself. So and okay, obviously planned for more than, I think 30 to 40 cases with Dr. Johnson Raja for zygomatic implants. You know for sure that this is a zygomatic implants are solid structures, no doubt about it. So why use that principle and get you the 3D option? So we made we said, okay, if they were to use a zygomatic implant, how they would use it. So the same zygomatic implant, we brought it over here. And then we took a support from the frontonasal region, a lot of support from the nasal bone that we got over here. And then we said, these are strong areas where bone is. So let's use them. And again, in the mandible, if you look at it, can you see here, you have to bypass the nerve, right? Because the initial implants, in our interest to start doing things, you normally would end up damaging your mental nerve. So again, a process which sits perfectly like that. That's the way the implant is. And these are the surgical photos. Very simple. Raise a nice flap, place the implant. Again, because of the implant is designed such a way, see the nerve is over here. You can confidently bypass the nerve. Don't need to worry about the nerve getting damaged at all. And see where the screws are being placed. Okay. So here you see, we placed about 1, 2, 3, 4, 5, 6, 7. I think we placed about 8 screws on both sides. We give you more provisions, but then you have an option. With just 8 screws on each side, you still will be very secure. The screws are conventional screws. You can use any brand. We prefer using Striker, but then you can use any brand that you want. That's the way it looks after surgery. That's the process that we designed. Again, I have my lab guy. We have an in-house lab guy with us who makes all these processes for us. The first set we normally would like to give it to you, but then after that it's all yours. If you have a prosthetic center who can support you, nothing like it. It's very straightforward, right? And that's the post-op X-ray that you have. Place the implant, take an impression. The process, temporary process is available the same day or the next day itself. The only problem again I said, do not cement it permanently, because the only way you can remove it is by cutting it. No tapping on the implant, because it will again make the screws loosen. So the only way, again, the only limitation in this is if you want to change your processes, you have to cut or break the processes. Other than that, everything else goes on perfect as per plan. So again, another small video only for the maxilla, where we did the maxilla was an atrophic maxilla, but the mandible was a conventional disc. So this is a patient who came to my clinic, and so this is how much bone that he had. All right, we could still do a conventional implant, but then I was not sure of loading it. The patient said, John, we need to load it immediately. So this was the anatomy that came inside. That's a customized implant. Again, another design. Just for you to know, there are different design options available for you. And here we do not give you a palatal extension. A lot of other customized implant companies today give you palatal options. We do not give you palatal options because we are not confident. These are all bicortical. So if you have a good buccal support, you can go bicortical and still support them. Okay. This is the implant placement. This is how much we actually did an exposure. As simple as that. Place the implant. If you notice, see the implant, no trimming, no adjustment of the bone, nor adjustment of the implant. It just goes and sits perfectly like that. That's the incision, and that's how easy it becomes. Prosthetic work, lab, we do the whole lab prosthetics part. That's how the implant looks, and after a week. So this is how the patient will present to you. I waited for a week because the healing was not okay. So we waited for a week before we loaded it. And that's the post-op X-ray. Down we had put in conventional implants. We used, I think Norris was the implant company that we used. We had amazing results. So that's us. Okay. So we saw atrophic maxilla mandible, a combination of an atrophic maxilla, normal mandible. What if you don't have the maxilla at all? This is where we had a patient come, Dr. Padmaraj, again, big thanks to him. He has this case where the patient had a history of a squamous cell carcinoma, removed, resected the maxilla, came after a few years, did all his scans, everything perfect, no recurrence. And then he said, John, can we do a restoration for him? So again, we used the same design where we used the studs. This was actually almost our first case with the stud pattern, which we had done it in, I think, 2017. So we have a close to 3-year follow-up on this patient. See the maxilla, there's nothing over here. This, if you can do for this, then you can do for anything else, right? So this is how the studs project out. That's his X-ray. That's his processes. We had done the framework. They had done it in the college itself. The framework was loaded, I think, about 2 to 3 weeks after that. They did the permanent framework, and the process is given for this patient. Back to work, no problem at all. So this is a patient which had a post-traumatic deformity. Again, from Dr. Srikanth, I'm showing you because this is sometimes we say, John, this is all fine, but what if the patient comes to us and he wants as an augmentation procedure? This is where there is no bone. You have the only problem is you need to think of a surgery, an advancement surgery, and then you need to take a fibula graft to compromise or compensate bone, right? How do you compensate bone over here? How do you get the patient to get back to his profile? Augmentation. Again, if the soft tissue is good, these implants work wonderfully well. So this is how the patient presented to you. So in this case, I was also not sure because this is the first time that we were doing it. So we did a prototype model and a lot of support from Dr. Srikanth. He said, John, whatever you say is fine with us. So he also pitched in wherever possible, gave us full freedom to plan it according to what we wanted. So see the anatomy and see the palatal. I only have the posterior molars with me. I don't have any of the anterior tooth at all with me. And I need to bring it at least to if not into a normal class 1, I don't want it to be into a very bad class 2, okay? And almost close to class 1 is what I want to bring in. So how do we bring so much of width? How do we add so much? So what we did is we made the processes first. So with my lab guy, what we did is we did the processes first, and then from here, what we did was a reverse planning. So this is the way we made it look like a class 1, and then we said if my process needs to sit here, this is the angulation that I want to get. See, all this flexibility you have with planning. Okay, so with customized plan, and then we saw where the bone was. Bone was good, support of bone was good, and then we said, okay, this is the way the implant needs to be designed. That's the design of the implant that we did. So this is how it looks. Again, another surprise which we had to encounter was the patient already had mini plates kept over here to keep his bone intact. And the doctor said, John, this has already been there for I think a couple of months to I think a year. So I can't remove it. If I remove it, I will lose whatever bone he had. So you compensate that also. No, you cover that out. That's possible with custom-made implant. You don't have to worry about trimming it or damaging the existing bone structures. So we made it round about it. Looked a little bulky. So, but this is the way it is. The maximum width that we were able to get, we gave a width of I think about 2.3 mm for it. No, we gave him that kind of a width, and then the rest of it we said we'll cover up with the soft tissue. This is the implant design that we came up with. That's the surgery. If you look at it, this is the way it's been placed. That's how it looks for him. I think about 3 or 4, 1 week after when they want to plan for suture removal. That's the X-ray. That's the processes. That's how we look. Okay. So patient is comfortable, pretty happy. I think that's the way you wanted his looks to be got, and that's where we go. So not just that, for posterior maxillas, like I said, another patient who came to us, this was an international patient who came and said, John, we only have a week's time. The patient has to need processes. Option was, again, the first option was zygoma. See, what we do is, we first give you an option of using standard conventional implants. Let's go for zygoma implant. Let's go for long, you have these basal implants. No, I said, okay, why don't we do basal implants and get the patient on so that we can straight away take an impression and go ahead with it. But the problem with basal implants was, this was my problem. Can you see this? This is where my sinuses are. See, my sinus lining is here. And here is where my bone is. This is how much I got. How do you get, I can probably get 1 implant, yes. But how do I get 2 implants over here and replace 3 teeth? That's the biggest challenge that we had. So this is the way we designed it. Can you see here? See, bypass the sinus totally, had good anchorage over here, and the main anchorage came from the zygomatic implant, a zygomatic bone. So like a zygomatic implant itself, we designed the structure again. So the whole screw goes from here all the way up to here. We did a, I think it was a 14 mm screw that we placed it. So 2 screws. So it's like you putting 2 zygomatic implants to secure it, and then the processes parts comes over here. Same like a zygoma implant. Okay. So design this. This is the way we designed it. Okay, it was a 13 mm screw that we had placed it. And here, these are the screw lengths that came in over here. So this option you have 10 mm, 9 mm over here. 13 is how much, anything more than 13, what will happen is you will end up coming on the other side. So that's the choice that you had to do.
5 minutes to wind up the presentation.
Done. Sure, 5 minutes, I'm done. So that's the implant, that's the case. This is the process that was designed. The zircon process was what we gave the patient. So posterior other options are there. For mandible, yes, again a patient who had a resection done. The only challenge here again was the nerve running very, very close. So we couldn't bypass the nerve. So how do you work on this patient? Right away did a custom implant. We took an impression just to know how much soft tissue we have. See, the implant is actually down. But see, when you superimpose the dental cast, see how much soft tissue you get. That's all you have. Take your impression and get the processes ready. These are a few again options of posterior implants where you don't want to do any grafting at all. No bypassing of the nerve. Straight away, load the implant, cover it well with good soft tissue, secure it, and come out. So how do we order this? Okay, now the question that you commonly, lots of cases are there. So how do we order? What do I need to do? Okay, first is everything starts with the DICOM data. So please take a CT scan or a CBCT scan. The minimum, if it's a guide or a model, it is fine. But if you want to do a custom-made implant, it has to be the most thinnest slice. Number 2 is dental profile or dental scan that you want to take it. And the last is these details is what we want. Okay, the history, complaint, medical history. Most important is get a patient consent signed ready. That's most important if they want to do on a customized implant. And a photograph intraoral extraoral, send it to us, we get it done. Cost, yes, cost was an issue, but now cost, because everything is done in India itself. We do it in India, we make it in India, and we're targeting, right now it's make in India, make for India. Slowly we're targeting make in India, make for the world. Cost is, I think it's going to be slightly lesser than what it would cost for a zygomatic implant or bone augmentation procedures. And that's what it is. So will 3D technology change everything? No, we are going on to virtual planning, virtual realities, bone augmentations. So big opportunities we have in all this in haptics, virtual reality, digital dentistry, and scanning. That's something that you can probably look at. So the future is actually in our hands. It's us, young surgeons, dentists, doctors, grab it. Don't lose this opportunity. Be ready for the change. These are the few hospitals that are working, we associate ourselves with, engineerings. And okay, this is something for you to know. This we recently got certified from the ISO 13485, which means that whatever product we have has a certification there. So you don't need to worry about certifications with us now. So these are the few things that came in. This was the one in 2016, like I said, the first print which we did came out in the newspaper. This patient is still having it. Like I said, it's about 2000, almost 4 years now. The first zygoma we did, a couple of things that came on the news. So a big support to my family, who's always been a constant support through all the things that we do. I mean, even yesterday, my wife, 1 o'clock, she said, John, you're troubling everyone up. So big support to them for bearing up with me. And thank you. Ruben, I hope I didn't exceed your time. So if you want any, these are the information.
Thank you once again. And it's now time for us for the question and answer session. We start with the first question. Why not conometric prosthesis?
Hey, yeah, conometric can be done. I think conometric, if you're talking about like these locator abutments, is that what he's talking about? I've not tried them, but we can probably look at that as an option if you want to look at a denture prosthesis. We can try. I've not tried it before, but we can try. Yes.
Thank you, sir. We move to the next question. Sir, is it not required to give threads on the custom-made implant designs?
No, not necessary. See, the custom-made implants, when you talk about it, you're talking purely about the abutment, the studs which stick out are like the abutments. Okay. Now the abutments, if you look at whatever we've done, we've never given a smooth, shiny surface. They are all matte finish. Matte finish helps in your cement to stick to them very hard. So, and now we are slowly coming up with these small threads like how I have your standard abutment. No? So I'm thinking, can we give like them? But they do not in any way increase the retention capabilities. You need to have a good resin cement if you want to cement them permanently. But other than that, yes, matte finish is good. Smooth surface finish, I would not want to do that. Yeah.
Patient-specific implants.
Success rate. Okay. Yeah. Okay. Out of the 50 that we have done, my success rate is 47. Two failed. Two failed in the sense. So one broke. We had to again. The reason why it broke was because of my fault. When we were trying to remove it, I was losing patience with the doctor. We were sitting. We were trying to remove the processes. It took us more than half an hour. Instead of us slowly trying to cut the implant, we used a lot of force, and then we cut in the wrong direction, and then the implant stud broke out. So when the stud broke out, this happened after a year. When the stud broke out, so we had to remove the whole implant. No, there's no other way of taking it. That's the only failure. Failure doesn't come with the manufacturing or with the planning. Failure can happen if you do not follow your prosthetic protocols. Yes.
Thank you, sir. Next question. Is the material used same as that of
Correct. Same. TI6AL4B. Same.
Thank you, sir. Next question. Does intraoral scanner is required instead of casts? What do you prefer?
No, both are fine with me. See, the biggest advantage when you have an intraoral scan is that the errors are limited. No, because you always can have errors when you pour the cast. There can be some errors when you're transferring. All those errors, that's the reason why scanners came in. Two things. One is you minimize the errors of you taking an impression, you pouring the cast, because materials vary. You know, sometimes we do an alginate. Not always do we use putty material and all. No? So those errors can happen. But then if you're able to get that sorted out, I think dental cast scan is more than sufficient, because scanners, not everywhere do we have a scanner, no intraoral scanner. Both are good as long as the impression comes out well. Yes.
Thank you, sir. Next question. How to change single processes if it fails? Or will it loosen if it leads to total loss of implant?
How to change the okay. No, a single process is the very rare. I mean, the chance of it failing is only if any standard methodology or sorry protocol that you'll use for conventional implants. No, patients shouldn't be should maintain if they are diabetic, they should maintain their diabetic status. The soft tissue should be very clean, no smoking. Those kinds of things, if they maintain, it will not fail. But if they do not follow these and there is a medical compromise issue, then yes, any implant would fail. If the bone, as long as the bone support is not there, the implant would fail. That's why, as a precaution, what we have done, Ruben, is we have these screws. No? So we keep extra screws instead of us normally having one or two screws. I give them about option of 5 or 6 in different angulations. So even if one screw loosens, you still have an angulation, the other screw which supports them. Rare chance, but can happen if the bone support is not there.
Thank you, sir. Last question. Patient had done with hemimandibulectomy after oral submucous cancerous. Post 2 years after this, is there any option regarding implant of this type?
Yeah, of course. I mean, that's what we do a lot. Now, if you look into our website, ctars3d.in, lots of options you have for hemimandibulectomy. We have done, I mean, we have slowly moving out of fibula, so you don't need to do a fibula grafting at all. Straight away do a custom framework 3D implant with the studs if you want to do the studs, so that you can straight away load it with the processes and the patient walks home, goes, discharges the 3rd day, has his process on the 6th day, out with it. So that's how fast we can do it.
Thank you, sir. Last question, I think, before we wind up the session. It says it was a fantastic presentation. What software do you use for planning, and what type of 3D printers do you suggest?
Okay, softwares. There are a lot of softwares that we can use for planning. There are two ways. If you want to plan for an implant positioning, then yes, you can use Blue Sky Bio is good. From 3Shape is fine. Mastro is good. DDX. All these are planning softwares you can use. For you to design an implant, it's either we use Geomagic Freeform. So Geomagic Freeform is one that you can use, or number 2 is you can use 3Matic, or any CAD. ExoCAD is also being used now. So these are the CAD softwares that you need to have for you to plan the designing. It's not that easy. It will take some time for you to get used to it. 3D printers to print. What are you printing? If you want to, you can only print the guides and the models. For them, you can use them with your Formlabs is something which I will really vouch for if you want to put guides. There are other printers also available, but Formlabs is good. The models, you can use any FDM printer. Any brand is fine as long as the machine comes out well. Metal, I mean, we use metal printers. No, they use 2 technologies, DMLS technology. So, I mean, I don't think you want to look at them unless you have a budget of about 2.5 to 3 crores. That's something which you can look at.
All right, so last question, and I think it's a very common question. We would like to know more about this concept, and can you please share your contact details?
Okay, I think I shared them there. Let me see if I can share them again.
You can reshare your screen, sir.
Okay.
I think that would be the best one.
Yeah.
All right, friends, I request you to kindly take a screenshot, kindly take a photograph, capture a photograph and save this photo as the contact details if you wish to know more about this concept, and if you wish to get in touch for a collaboration and for all your professional requirements with regards to this concept. Please take a photograph.